Medications for the endocrine system. So we're going to be looking at medications for diabetes, and then we're going to move on to some other endocrine disorders like thyroid and adrenal problems. Diabetes mellitus is a disease in which an inadequate amount of insulin is available for cells to metabolize carbohydrates. It's characterized by blood glucose levels that are elevated and can cause severe damage to the circulatory system in various parts of the body. When the body cannot balance the amount of insulin produced with the amount of carbohydrates ingested, an elevation in blood glucose occurs. Diabetes mellitus exists in two forms, type 1 and type 2. Type 1 diabetes occurs because the beta cells of the pancreas cease to produce insulin, resulting in insulin deficiency. It most commonly begins before the age of 30 and requires insulin for its management. Since it is a lifelong disorder, clients who have type 1 diabetes will need to take insulin throughout their lifetime. Type 2 diabetes occurs secondary to inadequate secretion of insulin for carbohydrates that are consumed, so inadequate secretion as opposed to no secretion for type 1. In addition, cells in the muscles, liver, and fatty tissue cannot effectively use the insulin, causing decreased insulin sensitivity or insulin resistance. Insulin's resistance by muscle and fatty tissues occurs when insulin receptors are no longer stimulated by the insulin, allowing the glucose in the blood to remain in the blood. Diabetes mellitus can cause hyperglycemia, an increase in sugar, hypertension, an increase in blood pressure, hyperlipidemia, an increase in lipids in the blood, and increased fat deposits around the torso, as well as elevated inflammation. Cells in the circulatory system are also adversely affected by high blood glucose levels, resulting in chronic small and large vessel cardiovascular and neurologic issues such as hyperlipidemia, hypertension, heart disease, kidney disease, peripheral vascular disease, myocardial infarctions, cerebral vascular accidents, retinopathy, and neuropathy. Acute complications of diabetes mellitus are hypoglycemia and diabetic ketoacidosis. Insulin resistance can progress to type 2 diabetes. The onset of this type of diabetes can occur at any age, but is most commonly diagnosed during adulthood and in clients who are overweight or obese. These clients frequently have a family history of type 2 diabetes. Early management of type 2 diabetes can often be done with a change in diet and exercise. As the disease progresses, oral hypoglycemics may be added to the therapeutic regime to control a client's blood glucose level. Management may involve more than one type of hypoglycemic because they work in different ways, so a combination approach is often more effective in keeping the blood glucose within the recommended range. Some clients in whom the disease continues to progress may eventually need to take insulin to adequately manage their blood glucose levels. A transient form of diabetes can occur during pregnancy and is called gestational diabetes. This is usually managed with diet and insulin until the baby is born, at which time the diabetes usually spontaneously resolves. The goal of medication therapy for endocrine disorders is to manage diabetes mellitus, thyroid disorders, hypothalamic disorders, and adrenal disorders, all of which we will talk about. This is a good slide to show you how insulin works in a normal person. So you eat some food and your blood sugar goes up from the sugar in the food. The pancreas detects this rise in glucose in your bloodstream, and so the beta cells of the pancreas start to release insulin in response. The insulin allows the glucose to enter the cells, and then the cells make energy from glucose, which is used by the body, or the body will store it in the fat, muscles, or liver to be used later on. That causes a decrease in your blood glucose. This slide gives you some good comparisons between type 1 diabetes and type 2 diabetes. For example, in type 1 diabetes, there is no insulin production from the pancreas, as opposed to type 2, where the pancreas either doesn't produce enough insulin or produces insulin that doesn't work properly. Type 1 is usually diagnosed in childhood. Type 2 is generally diagnosed in adulthood. One of the first things we need to know about diabetes is how to recognize hyperglycemia, too much sugar in the blood, versus hypoglycemia, not enough sugar in the blood. For hyperglycemia, we're going to have our 3 P's. Polyphagia, which means we're always hungry, polydipsia, meaning we're always thirsty, and polyuria, meaning that we pee a lot. For hypoglycemia, we're going to have things like tachycardia, palpitations, diaphoresis, which is that extensive sweating, and shakiness. Here are some signs and symptoms of type 1 diabetes. Here is a visual of signs and symptoms of hypoglycemia. It can be caused by excessive exercise, an excess of insulin, or insufficient food. All those things can cause you to have low blood sugar. The onset is usually rapid within 1 to 3 hours. You need sugar for your blood like it's in food, and your blood sugar is going to be less than 70 milligrams per deciliter. And then you've got your signs and symptoms here again. An easy mnemonic to help you remember is hot and dry means your sugar is high. If they're cold and clammy, they probably need some candy. Now we're going to talk about oral antidiabetics. Oral antidiabetics are going to be medications typically used by our type 2 diabetics. Type 2 diabetics are ones who can make their own insulin, but they've done things to their body to make it so weak that they can't. For a type 2 diabetic, insulin is not going to be our go-to choice. If it's going to be diet and exercise and then an oral medication. If later down the road that doesn't work, we will progress to insulin for a type 2, but it's not your starting point, whereas in type 1, your body is not allowing you to create any insulin. Type 1 is essentially a form of an autoimmune disorder, and so you need insulin in your body. Looking at our sulfonylureas to start with, glipizide's your big one for that. This medication helps stimulate our pancreas to make its own insulin, so this is great for type 2 diabetics who are not producing enough insulin because of their diet. This medication will not work for a type 1 because we can stimulate the pancreas all we want, but if it doesn't know how to create insulin, it won't. Our major adverse effect is going to be hypoglycemia. Your number one side effect for an oral antidiabetic is going to be low blood sugar because we can always lower it too much. A lot of these are also going to be no alcohol because of that reaction that we talked a little bit about with antibiotics. When alcohol reacts with certain antibiotics, the reaction is called a disulfiram-like reaction, which can cause symptoms like facial flushing, nausea, vomiting, headache, and rapid heartbeat. That can also happen with sulfonylureas. This is your flashcard for sulfonylureas. Glipizide or glucotrol is going to be your prototype medication. It's got your side effects on there. It also has the fact that we never give this to patients who have type 1 diabetes. And it also says in patients with type 2 diabetes who have a period of increased stress, their body can become even more hyperglycemic. They may need actual insulin to help them in those times. And this is the Picmonic version of information for sulfonylureas. As you can see, a lot of it is repetitive, but hopefully that'll get you to learn it. Next, we have our meglitinides. The prototype medication for this class is repiglinide. This class again causes the pancreas to release insulin. So, of course, it can cause hypoglycemia and nausea and vomiting. Again, this is also only for your type 2 diabetics. You have to monitor for signs and symptoms of hypoglycemia, which we'll talk about in a little bit. This class, biguanides, is very, very important. The prototype medication for this class is metformin. And what metformin does is it slows down your liver instead of working on the pancreas to make insulin. What metformin does is it slows the production of glucose in your liver so that your glucose doesn't go as high. Because of this, there is a lower or a decreased glucose absorption rate in the GI tract. This could cause some nausea, vomiting, gastrointestinal effects. Typically, they do subside over time, but sometimes not. Biguanide metformin is usually the drug of choice for type 2 diabetics. So if you start out as a type 2, this is what they're going to start putting you on. No alcohol with this. It can make you very sick, and you can get a B12 or a folic acid deficiency. So we need to monitor for that folic acid deficiency and replace as needed. You may even go ahead and put them on a B12 or folic acid supplement if you know that they're going to be on this. A lot of times this medication comes in an extended release form, so we're not going to crush it. And the big side effect of this class, metformin, is that it can cause lactic acidosis. Lactic acidosis is going to come from kidney failure. This medication is very, very toxic to the kidneys. So if you have a client who is on metformin, you need to stop it 24 hours before surgery. You also have to stop metformin 24 to 48 hours before contrast is given, because contrast is also very toxic for the kidneys and you don't want to double dose those. You can't restart metformin until 48 hours after the procedure or after contrast is given, and you have to have a normal kidney function test. So if it's been 50 hours but your BUN and creatinine kidney levels are still too high, then you can't give metformin. So don't forget to check kidney function, especially when patients are receiving contrast dye. Another thing to remember about metformin is that if the patient, or any hypoglycemic medication, is that if a patient is NPO, we want to make sure we're not giving them something to lower their blood sugar. And here's your mnemonic for metformin, also known as glucophage. Thiazolinide iones. The prototype for this class is pioglitazone. What this medication does is decreases our resistance to insulin, so it helps us utilize our insulin in our body a little more effectively. Of course, this medication can also cause the blood sugar in our body to go lower, but other side effects with this medication include fluid retention, high cholesterol, liver toxicity, upper respiratory infections, and headache and muscle pain. So if we get fluid retention, we want to make sure we monitor for things like edema and weight gain. Remember that weight gain is usually the best indicator of fluid being retained or lost. We also have to monitor our cholesterol levels and monitor the symptoms of liver toxicity. If a patient is taking Plavix with these types of medications, they could increase and strengthen the effects of the lowering of blood sugar. And because of the fluid overload side effect, we don't want to give these to patients with heart failure or fluid volume excess, because it's going to make both of those conditions worse. So now we have our alpha glucosidase inhibitors. The prototype for this is acarbose. It causes GI issues just because of how it's stopping the process throughout our GI system. It can cause iron deficiency anemia, so we may need to do things that help with that, like iron supplements. And then, of course, we want them to report any signs of iron deficiency anemia, like fatigue or pallor. We also need to monitor for hepatotoxicity. So any kind of dark urine, pain in the stomach, vomiting, fatigue, jaundice, anything like that. We've already talked about the side effect of hypoglycemia. Next, we have our gliptins. Sitagliptin is going to be the prototype medication for this class. It can cause upper respiratory infections and severe headaches. It can also cause pancreatitis, so we want to be really mindful of that. We also have to watch out for abdominal pain, because this could be a sign of pancreatitis. We can also get Stevens-Johnson syndrome from this type of medication, which is a very deadly rash. We're going to talk about that more with other drugs that cause this, but you have to be mindful if they get any type of rash. They can also get anaphylaxis and angioedema. But the biggest thing is that if you have GI upset that persists, or we have pain in the abdomen, we have to make sure that we're monitoring and reporting it, because it could be signs and symptoms of pancreatitis. Up next are our insulins. With insulins, we need to know what peak and onset is. Onset is how long it takes to start working, and peak is how long it takes to be doing the most work in the body. Duration is how long it lasts for the whole dose. When an insulin is peaking, The patients are at high risk for hypoglycemia, and we need to monitor for that and make sure they're given food. We have regular insulin that can be mixed with NPH, which is something that we'll be doing hopefully in lab in the next week or two. It's important to know that regular insulin is the only one that can be given in an IV. So the only medication that can be given as far as insulin goes is regular insulin. None of the others can be given IV, so remember that. NPH is an insulin that should be cloudy in the bottle. If any of the other ones are cloudy, you need to throw it away. Then there's long-acting insulin. This is going to be our glargine. Long-acting insulin should be given at the same time every day. It also cannot be mixed with anything. It has to be given by itself. Now for storage, when insulin is unopened, they can be kept in the refrigerator until the bottle's expiration date that's printed on there by the manufacturer. Once you open a vial of insulin, it can be stored at room temperature, but it must be discarded after 30 days. So it's really important to put the date and time on there so that you know when it has to be discarded. One of the side effects of insulin is also going to be low blood sugar, so you have to monitor for that. It can also cause low potassium, because what insulin will do is it'll take the potassium cells and take them out of the blood and move them with the glucose so you can get low potassium. So that means that regular insulin IV can also be a treatment for hyperkalemia or high potassium. When we administer medications, we want to rotate the sites within the same area. This is a good slide to show you the differences between rapid, short, intermediate, and long. I don't expect you to know the exact onset, peak, and duration, but you do need to know that Lispro and glucosine is very rapid acting. You need to know that regular insulin is short acting, NPH is intermediate acting, and the glargine insulin is long acting. This is a nice picmonic if you're a visual learner to show you that the different types take different amounts of time to onset, peak, and have different times of duration. This slide is good for the key points for storage, side effects, and administration for our visual learners. If we get the side effects of low sugar or low potassium, we can give potassium, or we can give something that has sugar in it, like glucagon, D5W, or oral carbohydrates. And then, of course, rotating sites prevent us from getting lipohypertrophy. So that means our fat tissue is not wasting away, so that we maintain good absorption of that injected insulin. We can also have non-insulin injectable medications. These medications are given subcutaneously, but because they're non-insulin injectables, they are not made of insulin. Pramlintide is going to decrease gastric emptying and inhibit the secretion of glucagon, so we can have some nausea and irritation at the site, and we definitely want to make sure to rotate our sites. Exenatide can help by releasing insulin and decreasing the secretion of glucagon, but it can also cause GI effects. We always want to notify the provider if they have those side effects, because it could be a sign of something bigger like pancreatitis. So exenatide, we want to be watching out for pancreatitis. Then lastly, for diabetes, we have our hyperglycemic agent, and glucagon is a prototype medication for hyperglycemic agents. This medication is going to increase our blood glucose. So this is given to someone whose blood glucose is too low. It's literally the antidote for low blood sugar. It can cause GI issues, nausea, and vomiting, and it's usually given IM. If someone has an IV running, we can give D5W, which is dextrose in water. So it's sugar water. We can give that IV to get someone's blood sugar up as well. Side effects with this medication can be GI distress like nausea and vomiting. It's like getting a sugar rush. I like the saying on this picmonic, glucagon when the sugar's gone. So that reminds you, if someone has hypoglycemia, we want to give them glucagon. So now we're going to move on to our other endocrine disorders. We'll start with the endocrine gland, the thyroid. When we think about thyroid levels, we need to look at things that are different than our normal thyroid levels. So you can have hyperthyroidism or increased thyroid, which is Tigger. He's orange, which means it's a warmer color. It's hot, so it means they're always hot and sweating and maybe even have diaphoresis. They can have a fever and things like abdominal cramping. If you think that Tigger is smaller than Eeyore, then you can remember that these people are going to have a lot of weight loss, even though they're still eating because their thyroid is metabolizing everything. They're going to have anxiety and tachycardia, which can lead to chest pain and tremors and heart palpitations, so we need to be mindful of those side effects. For hypothyroidism, we have sad Eeyore. He is blue. These people are going to be frigid and cold all the time. They're going to have dry skin. They're not really going to be able to eat. They may have anorexia where they aren't hungry, but they're still going to gain weight without even trying. They might also start retaining fluids and get edema. They may also have depression and drowsiness, bradycardia, fatigue, and things like that. Poor Eeyore. So now we'll look at the medications for the thyroid. The first medication we're going to look up is levothyroxine. And this is the only medication, the only option really to treat hypothyroidism. The common medication for this is Synthroid. The good news is there's only one side effect for you to really know, and that's like just with anything, we can over-medicate with the thyroid medication, give them too much, and that can cause signs and symptoms of hyperthyroidism. So the side effect of taking a thyroid hormone is you give too much. This slide is really good at laying out the side effects, which are the same as if someone has hyperthyroidism. We sometimes give this to pregnant women because when they're pregnant, their thyroid isn't working properly. We also can give it to people who have a thyroidectomy or have their thyroid removed. We have to replace that hormone, so we do it with Synthroid. The next type of medication we're going to talk about is PTU, profylthiouracil, and methimazole. These are both thiamide medications and are used to treat hyperthyroidism. We can also over-medicate or overgo the line and cause signs and symptoms of hypothyroidism. So we need to monitor for signs and symptoms of hypothyroidism when giving this medication. Another big thing is that this one can cause agranulocytosis. This is a decrease in white blood cells, so these patients might be at risk for infection. So we need to make sure they report things like fever, sore throat, and fatigue. We want these patients to avoid crowds. We want them to wash their hands and things like that. You can remember P for pregnant. PTU is the only one that is safe for pregnant women who have hyperthyroidism. We can have liver injury or hepatitis with PTU, so we need to remember to monitor for abdominal pain, dark urine, clay-colored stools, anorexia, abdominal distension, and things like that. Next, we have our radiopharmaceuticals, which is our radioactive iodine. This is a helpful medication for treating hyperthyroidism, especially the kind that can be caused by thyroid cancer. Because it's radioactive, it's going to have some of the same side effects as radiation, which might be like radiation sickness. Those signs and symptoms can be hemoptysis, which is vomiting up of blood, epistaxis, which is a bloody nose, nausea, vomiting, and a suppression in the bone marrow, the same things that radiation does. When you have suppression of the bone marrow, that's a decrease in the white blood cells, so you have your agranulocytosis, which is a decrease in platelets, which means they also have an increased risk for bleeding. So these patients are at risk for bleeding and infection. Then you also have to remember that when someone is on this, they have to have radioactive precautions. So that means maintaining a 6-foot distance from others. They should not be preparing food for others or sharing utensils. We're going to try and limit contact to 30 minutes per day per person. and we have to dispose of body waste as instructed because it could also have radioactivity in it. When we are the nurse caring for patients on this type of medication, we should wear dosimeters and be mindful that we could be being exposed to radiation from the medication that they're taking. This flashcard reminds us that radioactive drugs are not safe for women who are pregnant or lactating. It also gives you some other education points for our patients who are taking a radioactive medication. We can also give non-radioactive iodine products. So we don't have to worry about radiation sickness or radiation precautions on people who are taking these types of drugs. Iodine products are used to inhibit thyroid hormone and block the release of hormones into the bloodstream. Iodine helps with hyperthyroidism because we could have a lack of iodine, so the iodine will help with your thyroid function. Our goal would be to decrease the amount of thyroid hormone in the body. We typically use this in treatment of thyroid toxicities, which can be deadly, or if it's very high thyroid levels or a thyroid storm. Iodine medications can help reduce the size of the thyroid before it has to be removed surgically. But the side effect is iodinism, which means too much iodine. So with this, they can have a metallic taste, stomatitis, which is that inflammation or wounds on the inside of the mouth, which causes sore teeth and gums, headache, and skin rash. Sodium thiosulfate is what is given to reverse the iodine. Because we are giving so much iodine, we want to limit or eliminate other foods that can contain iodine, especially salt. Most of the salt that you get at the grocery store is going to be iodized salt, so if you're already taking iodine medication, you want to not have that kind of salt. Some seafoods can also contain iodine. We want to stay away from those if we're already taking a medication that is an iodine product. I like that this slide shows you what iodine does. You give a large amount of iodine, it inhibits thyroid production, it brings those hormones down, and then that can actually decrease the size and vascularity of the thyroid gland. So iodine can help us shrink that thyroid before we have to have it removed. So now we're going to talk about growth hormones. Somatropin is the prototype medication for this class of medications. Growth hormones are going to be used to help somebody who has growth hormone deficiencies, like Turner syndrome. It can also help if someone has wasting syndrome with HIV and AIDS, and it can also help to increase lean muscle mass in adults. Growth hormones are given IM or sub-Q. We have to monitor height and weight to make sure that patients receiving growth hormones are growing in the way and the amount that we want them to. Growth hormones can cause high blood sugar and high calcium, so that can actually cause renal calculi, which can in turn cause kidney issues. So in our patients with diabetes, we have to be very careful because this can increase their blood sugar even more. Next, we've got antidiuretic hormones like vasopressin and desmopressin. Antidiuretics stop you from peeing. So when we get to the cardiac system and we talk about diuretics, those are ones that are going to make you pee. This one stops you from peeing. We use these medications to treat diabetes insipidus and nocturnal enuresis, which means bedwetting at night. Diabetes insipidus means you continue to pee and there's no stopping it, so we're going to give you an antidiuretic hormone. If you stop peeing, of course, the side effect of this medication is we're going to fill up with water. So we do have a risk for water intoxication, which means there's too much water on the body. We want to make sure our patients report signs and symptoms of this, which might be pounding headaches, fatigue, fluid retention, weight gain, and edema. If patients are taking a medication that stops them from peeing, we may want to limit fluids during this time to prevent that water intoxication. Antidiuretic hormones can cause myocardial ischemia, which is going to be looking at dying heart tissue, so we need to make sure that patients report any kind of chest pain or chest pressure because what it's doing is constricting. It's vasoconstriction, so it's tightening up on our arteries and our vascular system so it can stop the blood flow from getting to the heart. So we have to be really mindful of that, and we wouldn't want to give this to anyone who has a cardiac condition. Up next, we have adrenal hormones. This is our glucocorticoids like hydrocortisone. So we talked about this a little bit with pain and inflammation, but when we're using it in the endocrine system, it's usually used to treat adrenal insufficiency for someone with Addison's disease. Typically the dosage is low, so you're not going to have a lot of side effects with this medication, as opposed to when we use it for pain. If the dose is too high, you can get high blood sugar, osteoporosis, adrenal suppression, peptic ulcers, and bleeding, which leads to GI discomfort. When taking adrenal hormones like corticosteroids, we also have a high risk of infection, so we want to monitor the CBC and glucose at all times. We also have the risk of putting them into Cushing's disease, which is an endocrine disorder, which is caused by prolonged exposure to high levels of the hormone cortisol. Cushing's disease occurs when the pituitary gland produces too much adenocorticotropic hormone, ACTH, which stimulates the adrenal glands to produce extra cortisol. When I said Addison's disease, that's the opposite of Cushing's. It's a rare endocrine disorder where the adrenal glands fail to produce sufficient amounts of the hormones cortisol and aldosterone. In the higher doses, we can have side effects like hyperglycemia, osteoporosis, decreased immunity and chance for infection, things like that. The following slides will give you more information from another PowerPoint I picked up for diabetes and from additional flashcards from Pharmacology, Nurse in the Making. So you want to follow ahead and read what's on those slides as well.